All right, it is 3 o'clock. Hello, everyone. My name is Karen Brownlee, and I am the Adult Program Coordinator at the North Suburban YMCA. And in that role, I bring all sorts of programs to adults in our community, including brain games, social networking, walking buddies, donation drives, a social club, a caregiver support group, and the Adult Education Series, which you are attending today. It is my pleasure to welcome you this afternoon to Illinois Bone and Joint Institute's virtual Adult Education Series program entitled Managing Chronic Pain, Pain Management Treatment During COVID-19 and Beyond, hosted by anesthesiologist and interventional pain management physician, Dr. Kellie Gates. Dr. Gates' interest in the field of pain medicine began during training with her desire to maintain continuity with her patients. She also has a passion for improving the patient condition. Dr. Gates sees pain medicine as a rapidly evolving field with multiple opportunities to impact and improve upon a person's quality of life. She treats each patient on an individual basis to find areas of pain management which they might be lacking. She also sees personal wellness as a key strategy for the management of pain. She believes that there are a myriad of ways in which overall general health can be optimized for patients, which in turn can promote improvement in chronic pain. We hope that you will gain a general understanding about managing pain from Dr. Gates' presentation today, and we hope to answer your questions throughout and at the end of the presentation. If you have questions, please type them into the questions section on your screen, and I will receive them and relay them to Dr. Gates, either during the presentation, if I can fit them in while she's talking about that particular subject, or I will bring them to her attention at the end of her presentation. Thank you for joining us today, and now please sit back, relax, and enjoy Dr. Gates' presentation about managing chronic pain. Thank you, Dr. Gates.
Hello. All right, I think this is gonna be it. Can you guys see my screen? I assume yes. This is kind of a new world for everybody doing the Zoom calls and the GoToWebinars, but I'm so excited to have everybody here and available to kind of hear a few things about managing chronic pain. COVID and the ongoing pandemic have definitely thrown a few changes into the way that we manage the pain for people, but ideally what we really want to do is make sure that we are optimizing everybody's care and getting people the access to care that they really need. So this is kind of just a very baseline discussion. Chronic pain and or just managing pain in general is a pretty robust field, but whatever I can do to kind of help everybody understand what's going on with their own bodies and kind of understand the ways that they can optimize their own care is what the goal of this presentation is ultimately. So like Karen said, very excited to be here and be able to kind of talk to you guys about it. This is about managing chronic pain, both during COVID-19 and beyond. So we'll kind of talk a little bit about all of it. I'm Kellie Gates. I was initially trained in anesthesia, and I did that at Loyola in the Chicago area, and then had a year of pain management fellowship that happened at Northwestern. Kind of love the Chicago area and love the people in here and love treating them and helping them however I can. So some of the objectives that I have for this presentation, ideally, I really think it's important to discuss some of the differences between, acute and immediate pain that has a shorter duration versus chronic ongoing pain that people have for a prolonged period of time. There are some key differences between the two, and it's important that people are aware of what goes into that. Also, just to give you a general idea of some of the common generators of ongoing pain for people, in medicine, I think it's easy for doctors and anybody in healthcare. We know what we're treating, and we see it so frequently that we forget kind of to translate what's in our head to our patients super frequently. So sometimes we throw around words like, arthritis and bursitis or stenosis, all these words that I think it's really important to kind of explain and give people an idea about what that means and what our goals are with treatment for those. So we'll kind of talk about those briefly as well. The third thing is to explore some treatment options, both some at-home treatments and then the treatments that we have available to us as healthcare in order to help with your ongoing symptoms, and then explain a little bit about how COVID has changed some of the management of the ongoing pain and decrease some accessibility to healthcare. So I like to explore how that affects people and how we can mitigate some of those negative impacts moving forward. And then I'll discuss very briefly just about what Illinois Bone and Joint is doing to help maintain the safety of the patients and some of the employees that work for IBJI as well, just to make sure that, you know, we don't know the timeline of this, we don't know how things are going to evolve, but to make sure that we're managing things as safe as possible. So we'll start just with the difference between certain pain types. And, you know, why is this important, I guess? Like, some people, or myself initially, I'm like, pain is pain, right? Why is there a difference between the two, and what does that actually mean for me and for the management of my pain? The main thing with this is the longer that a certain pain generator sticks around, and that meaning chronicity, it changes the way that your body and your brain mainly are processing that pain. So it can often make it a little bit different and or more difficult to treat fully. So I just like to go through those two differences between acute and chronic pain so that people kind of know that there is a difference, and also so they know, right, like if something is bothering you persistently or it's affecting your daily living, it's worth it to get it checked out. So duration, I'll talk about this as well. Chronic pain, we talk about it being longer than 6 months. Again, location, where is it, right? What happened before you got this pain? Was there a trauma? Was there an injury that can be repaired? Because, if there's something easily there that's repairable, it's very worth treating in the short term in order to prevent long-term problems with it. And then it changes our treatment options a little bit as well, knowing how long it's been around and how it's affecting you. The course of healing also too, if there's something that you should avoid weight bearing for, or some kind of different therapy can be instituted in order to help an acute injury to prevent it from becoming chronic. That's kind of something to keep in mind as well. And then my big thing, especially after seeing a lot of chronic pain, which is technically my field, is that it is so important for us to be able to maintain function for people. Just spoken for myself, right? If you get into an exercise regimen, or you get into something where you're feeling good and all of a sudden an injury or pain limits all of that, it's very easy to derail all of these amazing strides that people have made both in their wellness and their health. So to try to get people back to their functioning, or to maintain some good semblance of functioning and or exercise, is really important. And when you think about it too, people that are in pain for a long period of time, it definitely impacts their daily living, and it can, stop you from doing the things that you enjoy, lead to things like depression or anxiety, and worsen your sleep, which again is just things that we always want to avoid for people, because that just gets kind of a snowball effect. So acute pain really is pain that's secondary to a recent injury. So I always compare it to a toe stub, right? Like, you ram that big toe into a door and you know that it hurts, and it hurts pretty significantly, but over the course of 5 to 10 minutes, that slowly starts to die down and you're able to tolerate that pain a little bit better. It, oftentimes it can reflect a tissue injury, even if it's on a microscopic level, right? Even if you stub your toe and you're not bleeding, right? It still hurts. What happens in these acute pain settings is that there's certain hormones and inflammatory markers that start to really increase in the area that you initially hurt yourself. And then it creates this sensitivity to your brain saying, like, listen, if maybe I need to seek medical attention, or maybe I just need a Band-Aid for my boo-boo, something, one of the two, right? You maybe just need to pay attention to what's going on, or what initially was hurt. Like a paper cut's another good comparison, because both of those things is the tissue injury is real small, but those things do hurt. And then now more on the side of things, which I often see. So the chronic pain is like I said before, pain that lasts over, usually they categorize it as over 6 months. The thing that's kind of interesting about chronic pain is what can happen is maybe people had an initial tissue injury, or that has been propagated, and now if you get subsequent imaging, the tissue looks better, everything is healed, but people still have pain in that area. So it can occur with no tissue damage or injury at all on imaging. What we used to think before, kind of in the world of medicine, is tissue injury equals pain, worse tissue injury or worse tissue damage equals worse pain. And that's not always the case for chronic pain. It's kind of a very different phenomenon. So the longer that you're feeling that pain pathway, and I'll kind of pull up this picture because, this is a kind of fundamental view of the pain pathway, which it involves everything, right? Your brain included. the long-term pain exposure, it actually kind of excites some of those nerves. So it makes it so that it is a little bit more hyper than it usually is. And so you're more likely to feel that pain more consistently, as opposed to having, you know, those peaks and valleys and or that break from the pain. It can also alter some of your brain chemistry and mainly certain hormones. You can imagine if you're feeling pain for a prolonged period of time, certain hormones that are involved in you feeling that pain can become depleted because you have less of them because you're feeling the pain pretty significantly. So this can also cause, you know, they looked at some functional imaging to see that some of the brain centers, the pain centers, are a little more active in someone who's been in pain for a prolonged period of time. And then kind of like worst of all, it promotes people's anxiety and depression, which can decrease your pain coping for ongoing pathology. Maybe not even just that initial pain generator that you had, but any subsequent pain generators you might have in the future, which, you know, we age in one direction, right? Our bodies are, unfortunately, gravity is the worst and we tend to just age, and that is likely that intermittently you may have these painful like foci or incidences, but if you're dealing with chronic pain on top of it, it makes it a lot more difficult to manage. And then it also makes people vulnerable to certain social stressors throughout their life, not even necessarily linked to pain. So another big reason why chronic pain is, you know, worth getting taken care of or worth having someone's input on, and why it's, you know, its own field in the world of medicine. So I kind of stopped this big elaborate discussion just to say there are some kind of key take-home points that I like to talk about, at least just with acute versus chronic pain. The way that it's processed is vastly different between short-term and long-term, and the pain that becomes chronic can often be tougher to treat. So my big thing is if you are experiencing an ongoing issue, it's so worth getting, you know, treated, especially if those things are limiting your activity, limiting your ability to exercise, it's ruining your sleep, all of those awful things. And that last thing is said kind of, you know, as like a personal thing, because I have both a husband and a father who tend to just ignore healthcare problems altogether, and, you know, it'll go away, it's fine. But, you know, that's, I tell them both, right? Like, if it's changing the way that you're living, there are people that are out there that just want to help, you know, all over. So this is kind of where I'll talk a little bit about some of the common chronic pain generators, just again to just make it a little bit easier to understand some of the terms that are thrown around, or if yourself or a loved one has something and, you know, they're told they were diagnosed with this type of, you know, painful situation, you at least have an understanding of what's going on. So the chronic ones that I most often see, and I kind of say causes of these common chronic musculoskeletal pain, first and foremost, everybody has heard of arthritis. A lot of people have a certain degree of arthritis. So we'll go into arthritic pain and a little bit of the definition behind that too. You know, myofascial pain, which is a lot of muscular pain. People do have some degree of this frequently, and we'll talk about causes behind that too. And then, you know, a lot of what I see and like a big wave going on is just people with spine related pain, and a lot of it is back pain. You know, some of the studies that they're doing are saying as many as 15 to 20% of people, you know, even under the age of 60 have spine related pain, mainly low back pain, but, you know, above the age of 60, this multiplies as well. And so knowing what's going on with the low back and kind of ways that we can, or you can help, or we can help are worth noting for sure. And I kind of put this little line between the arthritis and the spine related pain because they do tend to go hand in hand in a number of different reasons, or a number of different, you know, mechanisms that I'll kind of talk about as well. So arthritic pain, we'll start there. And it's painful inflammation or stiffness of a joint. When we say joint, what we're just saying is a place where two bones tend to come together. So, you know, if you kind of take a look at your hands, right, you see that there are different hinge points in your fingers and in your wrists, and those are all separate joints. There you technically have, and I'll show you a picture, a number of different joints up and down the length of your spine as well. And since you can maybe see my your webcam, maybe not, but you move your head back and forth, or you twist your torso back and forth, and those are really what rely on the joints that are in both the neck and the low back. So when people talk about arthritis, I like to let you know that there are kind of two different types of arthritis that we often discuss. One is osteoarthritis, which is kind of like our aging wear and tear arthritis. This can also occur because of a previous trauma. Like if you were to have broken a wrist or broken an ankle or something like that, you are a little bit more prone to having arthritis in that area as time progresses. So that is what we refer to as osteoarthritis or OA. And then there's an autoimmune arthritis, which is rheumatoid arthritis. You know, many people have a family history of someone who's had arthritis. And so it's the treatment for the two of those is very, very different. And so it's worth, you know, the diagnosis of, you know, is it something genetic and autoimmune, which autoimmune just means that your body tends to attack certain joints in your, you know, because it's confused. And so it's, you know, attacking certain joints, which it's not supposed to do, but it does. So that's kind of what the autoimmune side of it. I'll focus a little bit more on the osteoarthritis or the wear and tear side of it just for today and for simplicity. Some common characteristics that come with the arthritis pain, it's very deep, it's an achy pain, you know, periods of inactivity, whether it's sitting or especially if you're lying in bed for a long, hopeful, restful night's sleep, you wake up and it just takes some time for you to get moving in the morning and get those joints lubricated up because, you know, the more time that there is for the inflammation to build up in those joints, the worse off your pain's going to be after that. So a lot of people notice morning stiffness, which is pretty common with arthritis. Hit or miss, but sometimes you can see joint swelling, which can happen. A lot of people see this in their knees particularly. And then you do get a decreased or a limited range of motion in all of those joints. You know, neck, low back, knees, hips, everything included if there's some inflammation in there. So causes like we talked about, the wear and tear, joint trauma like we mentioned. And then there are some data, you know, out there about any extra weight that we carry actually puts a pretty significant amount of pressure on some of the joints that we have. You know, but an article came out that said, you know, your knees actually, for every pound that you have, your knees experience kind of 6 times that. So especially when getting out of a chair, you know, if you put on 10 or 20 pounds, that's, you know, 60 to 120 pounds that your knees are dealing with every time that they stand up out of a chair. So that's a lot of, you know, that's a lot of pressure on that region. So a little bit more about the arthritic pain, some of the common joints that are involved. You know, people definitely get it in their hips, they get it in their knees, they can get it in their shoulders. Oftentimes, if it's, you know, to a very end stage point where it's really, really bad and it's not responding to the conservative measures, people get things like joint replacements, which is normal. And so there are other joints in the cervical spine as well, so and lumbar spine, which we talked about. And those often, the spine joints are the ones that give you that pain with bending and twisting. And so those are kind of how you distinguish some of that pain that you have, you can have in the spine itself. And so I kind of bring up this picture because the human spine is such like it's just an interesting design pattern. And you can kind of see here, this is a little kind of fundamental picture of what's going on in your spine. I'll use I'm not sure if you can see my mouse, you might not be able to. But what you see are these building blocks that stack on top of each other that are kind of the peach color. And then in between those are the discs, and those are blue. So when someone has it talks about like a disc herniation or a movement of the discs, it's just that the disc in here can sometimes get squished out. And you know, everything is food related, so I kind of compare it to like the cream in an Oreo cookie. If you push down hard enough, that disc has got to go somewhere, and so it kind of starts spilling out into the region nearby it and affecting some things. But you can see here that there is a, you know, the top is a separate bone and the next little part is a separate bone. So they create these facet joints, which are what can get some arthritis in them there. So then I kind of jump over to the next one, which is spine related pain. And a lot of times people refer this to as stenosis. So if you've heard of, you know, you have some narrowing in your cervical or lumbar spine, or if you have stenosis there, that is what this is referring to. And I'll bring up kind of a picture here again to help. But common characteristics of this, you know, people get this sciatica. That is often what is coming from the stenosis. So you get like a very shooting, burning like pain. It can go from your low back, it can go down into the leg as well, all the way to the foot most frequently. You can get like the numbness and tingling or the pins and needles sensation, which happens a lot more frequently than it usually does. So, you know, every so often someone's foot goes to sleep, but if it's happening every time you sit or stand for a prolonged period of time, this might be something that's going on. And so the pain into the arms or the legs, like the shooting pain that we talked about. Causes of this, you know, there's a lot of musculature and or ligaments that are responsible for holding the lumbar and cervical spine in place. Those can sometimes get weak over time if we're not using them as frequently as we should, and or if we're not strengthening them as well as we should. You can get disc bulges or herniations. So again, with this picture, luckily the discs again are a little bit of a blue color if you look at that picture. So you can see kind of the difference between a normal disc versus a herniated disc. And, you know, again, if maybe I'm just hungry, but the Oreo cookie phenomenon makes a lot of sense to me because again, if we're not maintaining good posture, if we don't have enough of the strength to hold that spine up, what happens is that disc gets a lot of pressure on it. It pushes down on, you know, that Oreo cookie, and then that spills out. And you can see from these pictures below, the nerves that are responsible for going down to your leg to giving you all the sensation and all the ability to move your leg are very close to where those discs are at. So they're very prone to being crowded, and they do not like being crowded. They're very high maintenance that way. And then also you can see that just behind those nerves are those facet joints we talked about. So joints, when they get arthritis, they can swell, and that is also close to some of those nerves there. So, you know, it's a very delicate process here, so that can sometimes happen as well. And our spines take a lot of stress for a number of different reasons, but mainly because I put a little picture of a skeleton here because you can see that the neck and the lumbar spine or the low back are definitely not stabilized by anything. They are pretty much just a rod that is responsible for like maintaining either your head, or they're maintaining your torso and your lower extremity. So you oftentimes will hear a lot of people talking about the importance of core strength. And why that is because of how prevalent low back pain is and how unsupported this lumbar spine tends to be on a daily basis, just because of the fact that it is, you know, your thoracic spine or up near where your chest is, that has the rib cage that keeps it in place. And then low down, you have your pelvis that's nice and stabilized, but that low back is just holding a lot. And it is reliant on a lot of that musculature particularly. So there's a lot of importance, right, in spinal ergonomics and or maintaining some of the integrity of your spine. I kind of talk to patients and I say, like, at one point we may have been four-legged animals and we're just still trying to figure out how to be how to walk around on two legs, because, you know, that lumbar spine is not super supported. So and there's kind of a reason for that. But what also happens is, you know, the desk jobs that we have or the sitting that we do, it puts a lot of stress on that low back, especially when you have bad posture with it. So it becomes really important, especially in light of COVID, when people are working from home, right? Maybe in your office, you had some amazing setup and your monitors are right in front of your face, and, you know, you were sitting with this ideal posture, and then you got home and you're, you know, oh my gosh, like sitting on your kitchen counter, eating a bowl of cereal and doing a Zoom call, or, you know, just all of that goes out the window. So making sure that the height of your computer is right in front of your face so that you're not, you know, sitting forward and kind of curving your neck forward. What's kind of interesting too is that they're starting to see in some of the younger generations our phone use and the way that we hold our phones and how it kind of curves our neck forward. It's actually starting to kind of straighten out our spines in the way that you don't want it to, and I'll show you a picture of that in just a bit. But so pay attention to how you are sitting and how you are standing, because most often we are not, you know, using the posture that we should be. And again, with core strength, you know, spine stress, also trauma, right? Anytime you have kind of a fall or things like that, it can definitely throw some things out of alignment. And then overuse. Everybody is one hand dominant unless you are lucky enough to be ambidextrous, which is, you know, pretty rare. But so what happens is you tend to overuse one side of your body, or your, you know, the way that you walk tends to favor one side or the other. So the overuse can really, you know, some of the muscles on one side of your body maybe go on vacation because they're not being used as often. And the ones on the other side are like, fine, I'll take over the brunt for this, you know, lazy left side on my, you know, when I talk about me, because I'm right-handed. So paying attention to these kind of things, and also that's where like physical therapy really comes into play, just to make sure that you're not overusing one side versus the other in particular. Also of note, when we talk about overuse, what can happen when people have, you know, lower extremity injury, whether it's your hip pain or your knee pain or foot, you can start to change the way that you walk, rightfully so, because you hurt, or if your back hurts. And that also can throw a few things out of alignment or weaken certain aspects of your musculature. So it becomes very important to, you know, be involved in rehabilitation and things like that if that's going on. And this is what I mentioned a little bit before about the phone use. On the right with the that green curve, that's kind of what you want to see. That's the specific curvature that your cervical spine is supposed to take. But what we're really starting to see is, again, with looking forward and using our computers and our phones, you get this straightening, which puts like an, you know, unprecedented amount of stress on certain discs and can kind of, you know, mess with some of the musculature too, and just provide ongoing painful generators. So then back to, you know, the pain generators that we primarily talk about, muscular pain, which is a big one as well. A lot of the times where we feel most of our muscular pain, and I'll pull up a picture, is throughout the neck and into the shoulders. A lot of this is posture related. A lot of this is overuse, right? Because you obviously have to, you know, pick things up, and you're emptying the dishwasher, and you're doing all of those activities that you have to do, and it definitely requires a lot of your neck, shoulders, and arms. So repetitive activities are particular overuse. Muscle trauma, right? Anytime you have a trauma, it can definitely make your symptoms worse. So characteristics for this one, again, are like a deep aching pain. Definitely worse with that overuse or worse with that activity. And sometimes people can feel those really painful knots, you know, they're like right in here. This pinpoint spot is super, super tight, and it's very, very tender. And that often can be something that's muscular in origin. So some contributing factors to these things are, you know, poor posture, and oddly enough, like terrible sleep or prolonged history of really bad sleep can actually, you know, it decreases your body's ability to get in some of that restful sleep, the REM sleep. And that's when your body's kind of regenerating some of those cells that were used or overused throughout the day. So you don't necessarily get the time to kind of regenerate some of those tissues if you're getting this like terrible fitful sleep. And then just briefly, I kind of want to talk about just a couple alternative conditions, just because, you know, what I basically talked about was the very tip of the iceberg with it all. But you know, some of these other conditions are thrown around and people have questions about what it is. So, you know, bursitis is something that people tend to get, and what a bursa is, and you can kind of see in this picture these little gel pads, these little blue healthy looking gel pads. And I'll pull up the next picture just for another kind of comparison. You can see here on the bone that there are certain locations where the muscles attach, and these like brighter red spots tend to be tendons. Those tendons really need something between themselves and the bone to help lubricate and make sure that that movement is really fluid and not real creaky, like, you know, the Tin Man. So I kind of compare the bursa to like the oil in a Tin Man, right? It keeps everything nice and lubricated and smooth moving. But what can happen is just those bursa can get inflamed for one reason or another, and that can cause some pretty severe like pinpoint pain, whether it's, you know, on the side of the hips or in the shoulder. And the second picture again is I say tendonitis, and what that can be is that the tendons, as they attach to the bone, they can become inflamed, and that can, you know, happen in a number of different places, hips and shoulders primarily. Tears of those tendons can also occur and can cause a pretty significant amount of pain. That's more of like an acute injury versus, you know, wear and tear for a long period of time. Sometimes you can get these like chronic tears over a long period of time. Ligaments, especially in the knee, people get like ACL or MCL tears. And then cartilage, you can get tears of certain meniscus in the knee that provide people with a lot of pain as well. Certain fractures, of course, you know, if you had a traumatic event, that's something that can cause ongoing pain for people. And then I pull this up because fibromyalgia is kind of something that people, you know, have heard about, or maybe if you suffer from yourself. But what fibromyalgia is, you know, it's a widespread pain condition, and kind of initially what it used to be was that we would really focus on these certain widespread tender points that people have. And you can see in this picture right there, they're everywhere. There are a lot of tender points that people tend to have. And kind of the more research that they do about fibromyalgia, what they're actually finding is that it tends to be a central sensitization is what they're calling it. Mainly, you are sensitized in your brain to all kind of pain generators, you know, especially certain the pinpoint locations that are listed in this picture, which technically are a lot of common locations where there's muscular pain or the myofascial pain. So it all kind of overlaps there. But fibromyalgia is kind of a tough condition because it is so widespread. It's not just one spot that's really bothering people. So some common treatments, and the way I approach it with all of my pain patients is I say, listen, there's like a very multi-dimensional approach for the way that you have to use it. It's not necessarily that like one pill or one thing is going to fix it in the long haul. You have to kind of field things as they go. So medications is one kind of piece to this puzzle, right? Physical and occupational therapy is definitely another. And then I'll talk briefly about some complementary and alternative medicine treatments, things like meditation and acupuncture, certain massage, yoga, right, that are really, kind of getting fueled with a lot of data as far as how much those help people with chronic conditions. Lifestyle change is another thing. I really just say, like, your overall wellness is obviously important to your ongoing management of all symptoms, everything in healthcare, including your pain, because anything that you do to take care of yourself holistically, whether it's your whole body or upstairs, including your brain, right? That everything is processed upstairs, so you got to take care of that. But you also have to take care of yourself, and find ways to do that. So psychological support is another one because chronic ongoing pain very much so can affect people's like mental and emotional well-being, and that the support that people have becomes very important when managing some of these symptoms, as well as interventional approaches, which is, a lot of what I do in clinic, right, is trying to figure out, what kind of injections can we do, what kind of neurostimulation, is this potentially a surgical pathology or something that needs to be treated with surgery, and ultimately it's, up to all of us in healthcare to help direct your path and figure out the best treatment for you. So I'll go through these kind of individually real briefly. So medications, right? There are a lot of over-the-counter medications that people, have or they utilize depending on what's worked for them in the past and what's safe with their current medication regimen. So things like Tylenol or Advil. I also am a big fan of certain topical agents like the BioFreeze or the Asper cream. I think it's just something that people don't really think of as an adjuvant to their care, and it's a great alternative. It's helpful for muscle pain, sometimes for that, like, the pain that people get in their wrists or their hands or their superficial joints. It's great for even in the neck. So that's worth something if you haven't thought about, using that as part of your regimen. It's worth looking into. And then certain prescribed medications, and this is kind of a topic for a whole different, part duh. We can talk about the kind of like the opioid epidemic and things like that, but we're really, a lot of research and a lot of efforts are going into finding non-opioid management, pain medications for the management of people's ongoing symptoms, because, as far as opioids go, they're still proven to be very good for things like acute pain, right? You have like something that just happened and you really need something to take the edge off while that healing occurs. But for the management of chronic ongoing pain, there's a lot of questioning behind whether are we doing the right thing? Are these actually improving people's pain states in the long run? And, that is kind of a case-by-case basis that you really have to look at it for people. So these are just some of the listed topicals. I really do love topicals, but these are some of the over-the-counter ones that I've heard of people using. Tiger Balm is one that I've used recently. It is very potent, and the scent of it burns people's eyeballs, but it works so well that I use it, much to my husband's dismay. And then Tylenol, right, is another, very easy over-the-counter analgesic. But of course, before instituting any kind of major persistent regimen, talk to your healthcare provider about that. So some of the physical and occupational therapy, the thought behind it is just some targeted movement and also like stretching and strengthening of certain musculature. I kind of digress because I have a story that I thought was kind of interesting. I, personally didn't really, especially in training, I didn't really have a lot of exposure to physical therapy, and I didn't really know, what is it and what good does it do. But there was a time in my life where I was, relatively in shape and I was working out, and I had the worst back pain, and I couldn't figure out why, because I had never been, lifting and doing as much. And I had a friend who's a physical therapist, and she told me, try this one maneuver, and it was a single leg squat. And like a turtle, I fell on the ground and couldn't get back up. I was just like flailing about. And she said, that musculature, it was one of my gluteus musculature. It's so weak on the left side because your form when you're exercising is terrible, and you were just relying on your right side. She gave me a couple exercises. Within a week, the whole thing went away. So it's, that's kind of the thought with the physical therapy side of it, is it's someone who is trained to look at you and see what you're doing that's potentially exacerbating some of the pain that you have. Are you walking in a certain way? Are you lifting in a certain way, et cetera, just to make sure that you're paying attention to it and it's not becoming an ongoing problem. So aqua therapy is another thing that I really love for people, especially that have, tough joints, right? It's this weightless location, but the resistance that you experience when going through the water is great for strength training, while also not worsening any kind of degeneration that you already have in some of your joints. Certain other therapies that are available, right, that sometimes physical therapy also includes, are massage, which is great, right, for some of that muscular pain. ultrasound, which also targets something similar, and then dry needling is basically the muscles can become so tight that sometimes you just have to slowly work a needle through them in order to loosen them up. It sounds a lot more barbaric than it is. The needles are very, very tiny, but ultimately it helps loosen things up so that you're not pathologically getting tighter and tighter in that same muscle. Ice and heat, I also love, and I think telling people about some of the common uses for ice and heat. Ice is really great for joints, or at least this is kind of my general rule of thumb. Sometimes you can test out, there's very rarely there are people that are like, listen, heat just works better for my joints, and that's fine. Ice is often what my go-to for people's joints, low back pain, neck pain especially, unless you have some muscular involvement where you're like, I feel it, it's these tight knots, it's the tension, then muscular is really good, really responsive to heat and that heat pad. So knowing what you're treating at home even, or knowing what kind of pain that you have, it becomes so important for people too. So that's kind of the difference between ice and heat. If you're planning on going on a long walk and you're like, I know my back responds to ice, but like I need to get warmed up, sit on a heating pad 5 to 10 minutes. That can really help to, make it so that that initial period of that walking isn't quite so painful. And then TENS units are another thing that we sometimes have people try out. Mainly what that does is it kind of puts a nice little vibrational sensation over the point where there's pain. And basically the thought behind it is you can really only process one sensation at once, whether it's vibration or pain. So if you are, sticking with that like buzzing sensation, then your brain's kind of confused and it's like, I can't feel the pain. All I feel is vibration, and that's fine, right? That's a little bit better than feeling that chronic ongoing pain. So that's kind of a little bit of the thought behind the TENS unit. The less movement that's being done, the harder it tends to be to maintain your strength and mobility. Another kind of anecdotal thing someone once told me was, and this is more of a hospital setting post-surgically, but one day where someone sits in bed instead of kind of moving around, rehabbing certain things, it requires almost 7 days in rehab in order to get back to the strength that you were at the day before. So I have a lot of people that come in and their pain is so bad that they said, I've been sitting on the couch for 2 weeks. And to me, that kind of breaks my heart, because I'm like, okay, I just prepare you. There's a decent, there's a long road ahead for us to get you back to where you were. But treat yourself with some grace. It's going to take time, but baby steps will get you the way. Rome wasn't built in a day, kind of thing. And then the complementary and alternative treatments that I kind of mentioned about before, massage therapy, amazing for that muscular pain that we kind of talked about as well. It definitely helps to break down some of that tissue tension. Acupuncture is also becoming more and more like approved and relied on in Western medicine. It obviously is like kind of founded in Eastern medicine, but there are certain things like back and neck pain, osteoarthritis pain, migraines, that are really responsive to this, that's being shown through data time and time again. So I always wonder, what's the mechanism behind something like that? How does that work? So it uses certain pressure points, and either using needles, heat, or just pressure in general, it gets to those tension points. And the thought behind the Eastern medicine side of things is that it redirects or stabilizes some of the body's natural energy. What I saw a study that also said that some of these points also tend to correlate with certain really bad muscular tension points that people tend to have. So there's a lot of overlap there as well. It also tends to increase some of your body's natural endorphin levels, which are actually, we call them like a natural opioid. It's like a natural painkiller that occurs in your body, the endorphins are. So that's kind of, that's kind of the mechanism behind it. And then meditation, right? It definitely shows some significant chronic pain reduction if you do that, if you get into a good regimen with it, especially. So some other treatments that we have, right, are just lifestyle changes that I kind of talked to people about. Exercise, however you can do it. It's not necessarily going out and running 5 miles, because that's like impossible. I mean, not impossible, it's possible for me, but at this point, because I haven't trained for it. But any exercise that you do, anything that kind of increases your heart rate, like we talked about with the endorphins, exercise releases a lot of natural endorphins, which are kind of our body's personal painkillers. So it does, over the long term, help to decrease some of people's pain scores the more consistent they are with their exercising. And there is always fear that it's going to hurt or worsen their pain, but you cannot let that fear stop you from doing the things that you can. So it just becomes very important to find a good regimen that works for you. Diet and nutrition are also huge, right? a lot of the things that we eat or the things that we incorporate in our bodies can be pro-inflammatory. And, you know, the more inflammation that you have throughout your body, kind of like they're coming to find that it's worse off in a number of different ways. And it also definitely impacts some of the stability and the health of certain joints in your body. Weight loss also, right? We talked about the stress that it can put on joints. And also kind of interesting is that some of the adipose or the fat tissue that we hold in our body actually can secrete some inflammatory markers throughout our into our bloodstream and throughout our system, which again just kind of puts you in this inflammatory state, which ultimately doesn't you know, it doesn't help your health in any ways, but specifically with your pain. Smoking cessation is another one that actually can help as well due to some of the inflammatory nature of what comes with ongoing smoking. And then optimizing people's sleep is kind of my baby. It's like my pet project, because I come to find that a lot of people have either dealt with or lived with really terrible sleep patterns, and you know they found their own personal ways to cope with it, but it, you know, it doesn't have to be that way, and it shouldn't be that way, right? If you're not getting great sleep, it definitely in the long term can worsen pain states. So always thinking about sleep hygiene, right? Do not sleep with a TV on. It really decreases your brain's ability to get into REM sleep. What you really ultimately need is either a very quiet room or a room with some white noise. It needs to be dark. It should be cool. Try also to go to sleep and wake up in the same window of time. Mainly, that's like a couple hours, right? Like, you know, if you're like me and you go to bed at 9 because you just love sleeping, you know, on weekends you can still be kind of fun and stay out till 11, but really try to keep it within that 2-hour time window. Otherwise it throws off your circadian rhythm quite a bit. So really focusing on sleep is a big one too. You know, that's what I'd love to look like when I'm running, but usually I'm like walking at a leisurely pace. And here is someone who loves sleep, and that's my 16-month-old Hugh. He is probably the best sleeper out there. So some of the treatments, again, we talked about psychological support, and just a little bit more about that, because I think that's really important and often something that we tend to neglect in medicine. You know, depression and anxiety do play a major role in chronic pain, and there's reasons behind this. Often, who knows what starts it? Either it's chronic pain or it's people that are feeling, you know, most of the time people will come in to my clinic and they'll say like, the pain has made obviously my depression or my anxiety worse. But either way, all I know is that certain pain states and depression tend to utilize some of the same hormones. And so if you are chronically in pain, those hormones, like we talked about before, are decreased in your brain. And those, if you sample hormones, you know, in people that are chronically depressed or people in chronic pain, those hormones are low in both populations. So there is really some overlap of this going on. And, you know, if you take someone in no pain and then they've been in 6 months worth of pain, almost 50 to 60% of patients after 6 months of pain are going to start exhibiting some signs of depression on screening. So, you know, again, very worthwhile to get things taken care of. If you are in pain, you don't need to like grin and bear it. There are people to help. And also, if you're kind of lacking in the support in this area, it winds up contributing to worsening outcomes for people, right? Like your activity is decreased, and thus, like we talked about before, it gets a lot harder for you to reinstitute some of that activity. Depression or anxiety are found to have poor sleeping habit, like the sleep is also affected, which is something that we also talked about, and then diminished pain coping, which is ultimately, you know, rough in the long term. So we really should prioritize mental and emotional health for people. It's so important. And then some interventional things, like this is obviously a lot of what goes on in my office, but injections really are targeting inflammation. So that's targeting inflammation at certain joints within certain bursas, right? Or specifically in certain nerve roots for people who are having that sciatica pain, right? All of these things are inflamed. Whether your nerve is causing you this sciatic shooting pain, it's because it's being, you know, touched by something nearby and it's inflamed. Your bursa, there's some inflammation in there and it causes some pain, and joints. If you have arthritis, right, that is inflammation as well. So anything that we can do, the injections are primarily focusing a lot of the time on steroid, and steroid is kind of the best thing that we have to decrease inflammation, so that's why we use it. Some people have maybe heard about what's called a radiofrequency ablation and or an ablation procedure, and that's primarily used for the neck and the low back joint related pain. There are very tiny nerves that are responsible for supplying the pain sensation to those facet joints. And basically what you do is very, very pin tip size little targeted burn lesions that help to decrease that pain communication to your brain and ultimately let you be pain free for, up to 2 years, which is kind of nice. The unfortunate thing about neck and back arthritis is that you can't necessarily take it away. There's really no back joint replacement, so you kind of have to find alternative ways to take care of it. That's kind of those facet joints that I talked about, and they're very, very tiny nerves that sit over those joints. They're not even included in this picture because they are so tiny, but those are the ones that you go after for those ablation procedures. Something else that people may have heard of, which is called neuromodulation or spinal cord stimulator. It's an implantable device that you surgically get placed that lives in your spine, and that helps to kind of decrease some of the pain signals that are going up to your brain. Again, something to talk to a specialist about. And then ultimately, surgical interventions, right? If this is not getting better and it's just been going on for a prolonged period of time, despite everything that we've thrown at it, sometimes, the surgical route is the route to go, because then you can just immediately get on rehabbing and taking care of that new joint or that new back or whatever, was operated on. And then in light of COVID, right, there's been some major adjustments to this because the access to this has been so limited. So I'll talk about that very, very briefly. So this is kind of getting to the tail end of it. I know it's been quite robust, but the pain management during COVID, there's limitations and some very critical pain management techniques, mainly like physical therapy has been difficult to get into. We've been trying to manage things via telemedicine or telehealth, which is not often the same as far as just physically examining people and seeing them in office and being able to take x-rays and diagnose. So, we're kind of like, in at least the last few months, it was doing what you can to make sure that people are doing okay and that they're comfortable, and trying to see if there's anything acute that needs to be taken care of, like who needs to be seen in office and how to do that safely. So, that's the telehealth kind of thing, which honestly, I don't think is going away anytime soon. I think telehealth will continue to be integrated into some of your healthcare. So, the best thing that you can do is really equip yourself with some, if it's figuring out how to manage your computer when you're getting on these telehealth appointments, or really getting someone who's open to doing phone calls or things like that. That's very important, because it's I think it's here to stay. And then physical therapy too, right? Are some telehealth options for that. They can definitely see you via like a video encounter and give you some recommendations about exercises that you can do at home yourself, which are ultimately what will help you in the long run anyways. And then, some of the cancellation and the stalling of elective procedures, like surgeries or injections, it really leads to a major postponement of treatment for people, which is ultimately quite, stressful. And when we kind of talked about, people's ongoing mental health and how that impacts their pain, right? Stress and cortisol levels 100% worsen people's pain states as well. So if anything, this time in our, in our world is wildly stressful. So it definitely is impacting people's pain states, and then not being able to access some of the things that would ultimately take care of them. It's, it can definitely exacerbate people's anxiety and or, mental health. There's also kind of limitations in movement, like where can you walk to? Is there, can I be outside kind of thing? There's gym closures, there's like a limited outdoor access, as well as decreased access to adjuvant therapies that may have been helping, such as aqua therapy, massage therapy, or acupuncture. And then the increased situational stress, like we talked about, which have those adverse effects. So, the closed because of the coronavirus kind of stuff definitely puts a damper on things. So then I kind of just briefly will talk about what Illinois Bone and Joint is doing, just so like, if you are feeling like, okay, I'm kind of ready to get some of these things taken care of, but I'm nervous, right, to get out amidst everything that's going on. There are huge precautions being taken. Just even these are just some of them, right? But it's, masks and gloves and cleaning and sanitizing that's happening between every patient. We are very much so promoting social distancing. So the staggering of appointments to make sure that there are not too many people in the waiting room at a given period of time, so everybody can keep their 6 feet from each other while they're also wearing their masks. And then with personnel too, optimizing who can work from home, right? Who is able to do that, so they're not one more exposure risk for themselves and also for patients, of course. And then like I said, with the limiting of the patient's appointment, which decreases overlap and patient density, and then gradual reopening, right? So we're slowly starting to reopen some of our offices, which have been closed just to limit traffic, and doing so in kind of a methodical manner to make sure that everybody is staying as safe as possible. So at this time, that is all that I have. I really appreciate you listening to all of it, but would love questions if people have them.
Yes, I have a bunch of questions here that I am happy to share with you. I'm back, Karen. Okay, so this comes from Barbara. She says, I have been treating arthritis in knee with periodic viscosupplementation injections. Will postponing treatment cause worsening of the joint deterioration?
You know, in viscosupplementation, actually, it's been shown to build up some of the cartilage within the joint specifically, which is nice, obviously, because it helps to prevent some of that breakdown. And the prevention of surgery can be up to 2 years for people doing the viscosupplementation. So ultimately, that gets you some strength rebuilding and things like that as well, which is great.
And so will the postponing of the treatment worsen the joint deterioration?
Not necessarily, no. No. And as long as, especially with the joints, as long as you are not doing a lot of like the running and some of the high impact things, that those definitely do impact some of the joint health. That's ultimately what you would like to avoid. So as long as you're avoiding some of those things and doing things like cycling or elliptical and things like that, that's, those are what you'd like to stick with to maintain the strength of the joint.
Sounds good. This one is from Elaine. She says, I was diagnosed with having discoid lateral meniscus and arthritis behind my kneecap. Is it strange to feel like you're having an increase in pain even when you've lost weight? I make sure that I drink 8 to 11 cups of water a day, but I am also noticing constant cramps in my feet or around my knee area. Is that a blood flow issue, or is there some type of exercises that I can do to help me with the issue? I don't like taking the pain medications because of how it makes my heart race rapidly. I'm
Yep.
trying to find alternative methods to help me out.
I think it's worth, I'm not exactly sure as far as follow-up has gone, but it's definitely worth being seen, especially as things kind of go down into the, ankles and the lower part of the leg, just to make sure that it isn't something vascular related or something coming from the back. There are a lot of things that ultimately kind of worsen some of those symptoms. So it's definitely worth getting checked out.
Okay, great, great. And then we've got another question from Ronald, which says, I have had both knees replaced, the right on January 20th and the left on March 2nd. I have muscle pain in my quads. I know that they are weak. I have gone through all of the rehabilitation and now I'm at home to finish. I walk, ride bikes, and work on the stairs. Is there more that I can do? Well, I know the answer to that too, but I'll let you, as a personal trainer, I can help too, but yes, I'll let you answer.
And I think that's, getting someone, and that's kind of why I touched on the physical therapy side of things, right? Getting someone who is specialized and knowing exactly what is weak, right? It feels like it might just be the quads, but maybe there's some other, musculature that's in the pelvis that is also not, picking up its end of the bargain, right? So to get to someone who can evaluate kind of where your weakness is and what's going on with that, a lot of the times, right, personal training or physical therapy or things like that are very, very influential for that.
Excellent. And then Kathy asks, food eaten affects pain, question mark? Does weather affect pain, question mark?
There are actually some studies about the barometric pressure and or like changes in weather affecting people that have ongoing arthritis, whether it's osteoarthritis or that autoimmune arthritis. It's interesting because they said, humidity and heat are actually the worst. So some of those like arid climates, I have a lot of people that are snowbirds and they tend to go to either, Arizona or somewhere that's a lot drier, and they notice that their symptoms are improved. So there is data behind that. It's not in people's heads. And then also with the inflammation that's associated with some of the foods that you eat, I really focus on people trying to figure out what their specific triggers are, right? Like if you know that going into a night and you have a glass of wine or you have a giant slice of chocolate cake, right? And that is going to affect your symptoms the next day, at least you can link it to that and you can kind of know what to expect, because some of those are very pro-inflammatory and it's, it's not imagined. It absolutely is something that can worsen your symptoms.
Great, thank you. And Virginia asks, can you repeat the external creams you use and what are your thoughts on using those? And you mentioned it a little bit in your talk.
Yeah, I think the most common ones that I see from patients are Salonpas or BioFreeze. Asper cream is another good one. They all have some degree of a topical anesthetic or like a lidocaine in them, or some variant of lidocaine. So I think that some people, when using them in their kind of in their chronic ongoing treatment, they really do have good luck with them. It just depends on when you use it, right? And a lot of people will use it on the musculature in the neck. They'll use it on the hands. They'll use it before bedtime in order to optimize the sleep that they're getting. That's kind of like the big thing there.
Great, great. Irv asks, when would it be, it says when to see sports injury specialists for injuries not from sports, including joints that have arthritis?
That actually is a pretty great question, because a lot of the sports injury physicians are actually, they're orthopedic trained, right? So they've seen all of these things, and they know how to treat all of these things. So it's kind of nice actually having kind of a quarterback to like dedicate or dictate where to go with it too, and what's the next steps in it. And any orthopedist or pain management, like physical medicine and rehabilitation physician or healthcare worker, they will know where to send you. So you're in good hands.
Great, great. Debbie asks, what is your opinion of the safety and effectiveness of chiropractic care?
I think with chiropractic, actually, I have like a couple good friends that are chiropractors, and I kind of asked them a little bit about it as well. They often try to incorporate certain methods that we also use in physical therapy, meaning like traction, which is gentle, like strength, stretching and elongating of the spine, as well as some physical therapy maneuvers. They will definitely give you things like here, foam roll this certain muscle or do things like that. So it's someone who's really looking at some of the ergonomics of your spine. There are some safety concerns with the cervical spine, especially. It's just not meant to be manipulated super quickly one way or the other. So that's kind of where I take a little bit of hesitancy. But I personally had some good luck with my friend who helped me with some back pain in chiropractic. So just using it as a part of your regimen is not necessarily, I would never deter you from that.
Okay. And Jeff asks, what is the difference between acupuncture and dry needling?
So acupuncture is just you put the needle actually into the point and it stays in that location. Dry needling is it gently kind of works through that musculature. So it's a moving target. You are like moving that needle throughout, and that helps to break up some of the, technically what's around the musculature is called fascia. And I compare it to sausage casing, like keeps the muscle intact, but it's really, really tight, or it can be really, really tight. So what dry needling is ultimately trying to break up some of that fascia.
Gotcha.
And
That
that's,
helps a lot.
yeah.
That makes a lot of sense. Thank you. Nancy asks, is radio frequency ablation recommended for spinal stenosis?
No, no. Spinal stenosis in and of itself is, that narrowing that you see in the spinal canal, which causes some of that nerve impingement or some of that pain that you have. The ablation is really only for those joints that you have in the back, which is something that's a little bit different. Most of the time, the joints in the back are going to cause just back pain, and stenosis or that nerve impingement will cause pain that goes down into the leg. And this, again, take it with a grain of salt. It's a rule of thumb, right? Obviously, it's nice to talk to someone who can ultimately diagnose that, but those are kind of the differences. But spinal stenosis doesn't respond super well on its own to ablation.
Okay. Janet wants to know, how about low weight and pain?
Pain, like low personal weight or low weight?
I think so. Yes, I think. Yeah.
Okay. And that's people can get pain no matter where they stand on kind of the weight spectrum. It's tough too, because a lot of the times, right, we'll say, extra weight that you carry worsens your joints, but I see people, who are underweight, who still have joint degeneration, who still have issues with it from overuse, or sometimes, you're genetically predisposed to it, like, thanks mom, right? But it happens no matter what. But depending on what the pathology is, it can be coming from different generators.
Got it. Got it. Janet also asks, and I don't know if it's the same Janet, have you heard of Gokale posture method? She says it's helping her as much as physical therapy. I don't know what that is. Do you know what that is?
No, I don't, but can you spell it? Because I kind of want to look it up.
Yep. Gokhale. Gokhale.
Okay. I haven't heard of it actually. I do know though that anything that you can do to do some posture training, it takes, well, and three things, right? There are a couple different ways that you put pressure on the discs and on the spine. If you are sitting with bad posture, that hands down puts the most pressure on your spine out of any positioning that you have. If you are sitting down with decent posture, much less pressure. And then if you're laying flat, that's obviously the least amount of pressure you can put on your spine. But I mean, in studies time and time again, if you're sitting with bad posture, that is crushing your discs and your spine there. So posture training, great. I'm all about it.
Great, great. Becky asks, can you explain what visco sub is?
Visco supplementation. So it's like a big fancy name for something that they came up with because in certain joints, mainly the knee, that's really where most of the data is for it. You have cartilage in your knee that it kind of thins out over time, and what can happen, and that's when people get the bone on bone phenomenon, because your bones aren't supposed to be touching, they're supposed to be something between them, but if that cartilage gets real thin, they tend to kind of rub up against each other. So what that visco supplementation is that it replenishes some of the cartilage components within the knee in order to kind of help rebuild that and or maintain whatever cartilage you currently have, so you can prevent that bone on bone phenomenon that people hate so much. But usually what the stepwise process is people stick with conservative therapy for it initially. So like if you have knee pain, we say, okay, go conservative, right? And do your physical therapy, do maybe some topicals, do some anti-inflammatories or whatever you can tolerate. Then the next step is steroids, because oftentimes people will respond to steroids pretty well. And if you're not responding to steroids, then you start jumping to that visco supplementation. There's really no benefit in jumping straight to it.
Because the other things might work.
Exactly.
Right, okay. Do you have time for any more questions? I know we've hit 4 o'clock. We've got about maybe 8 more questions.
I am free as a bird, so.
Okay. Patricia says, I fell on my right side 2 weeks ago, and my knee and shoulder are still bothering me. Whom should I see first?
There are a couple different routes to go, and I actually thought about including this in my presentation, but I didn't. Ultimately, you can see your primary, or when it becomes something that's musculoskeletal like this, I actually love what IBJI has created, because they have something that's called ortho access, which is, you can go in and be seen by an orthopedic surgeon who, if anybody on this planet knows bones and joints and ligaments and musculature, it is ortho. That's what they do. That's, so it's a nice, it's a very nice option to make sure that there's nothing that's ongoing or, that needs immediate attention as far as care goes, and then where to direct it to make sure that, 2 weeks is good enough time to see, like, is this going to go away on its own? So it's nice to get someone's opinion on it.
Great, thank you. Okay, let's see. This one from Bruce says, injections in knee, better peripheral or direct in knee meniscus?
It's hard to say as far as what peripheral means and what you're treating, because I actually don't know exactly what's going on with the knee.
Right.
There are a few different, you can definitely have some ligaments that are lax, or there's some cartilage or things like that. But usually when you're putting steroid or injections into the knee, you're going into the joint space, which is where that cartilage lives, to help decrease some of that inflammation.
Okay. So it really will be up to their doctor.
Yeah. And based off of imaging and what x-rays and things like that, or whatever they see.
Great. Okay. And then Ellen asks, will spinal ablation help neuropathy, and is it safe to do PT with COVID-19?
The neuropathy, the ablation does not help with neuropathy either. Unfortunately, again, it's mostly just that axial, we call it axial, but just means the pain that sticks in the low back, not anything that kind of goes into the feet or into the leg kind of thing.
Okay.
Safety during COVID is always a question, that we're trying to approach too. And so that's why a lot of the precautions are in place, right? It's 100% safe for you to actively do PT. How you get there is kind of ultimately what we leave up to patients. People are wearing masks, people are wearing gloves, we're keeping distance away from each other and away from other patients too. So if it was like myself or a family member and they were, hurting and needed some care, I would say go for it, right? Ideally, you'd get some exercises and be able to follow up as needed via telephone or virtual visit. Most of the time what the physical therapists do is they really dictate based off of your first encounter, like, hey, how often do we need to have you in clinic? Or, can we do a lot of this virtually, just to make sure everybody's goal is to limit exposure. So you're in good hands.
Great. Charles asks, is Bengay cream good to use?
Yeah, that's another topical, again, that is a decent agent to try out, definitely. I haven't really had much like one is better than the other kind of experience. It becomes mostly trial and error for people. Like which one is your topical of choice?
Gotcha. Okay. And I don't know if this is a topical or not, but Nancy asks, what about Valterin? Is that a topical too?
It is actually. And Voltaren actually just became an over-the-counter agent. So, you know, it's another, I think it became an over-the-counter agent after the time that I created that presentation, which was like a week ago. So it's actually kind of interesting because what Voltaren is it's a topical anti-inflammatory. So it's like an Aleve in a gel form, which is actually a really good option because a lot of people are on blood thinners or they can't take anti-inflammatories, or they have, you know, kidney disease, or for what they've had previous ulcers or things like that. So the topical version of it's actually a decent option because, you know, I've run it past nephrologists, I've talked to cardiologists about it, and the uptake that you have from the topical version is so minimal that people don't, they kind of say, do what you will, you know?
Yeah, got it.
Fine.
And it asks, Lori asks, what meds have you had most success with for severe intractable nerve pain in the feet, peripheral neuropathy?
There are a few different subclasses of nerve pain medications that you can kind of try out with people. A lot of people will have initially tried either gabapentin or Lyrica as like a subclass. You know, what happens frequently with those medications is that people think that they're not effective before they've actually worked up to like a higher level of the medication. So sometimes it takes a longer trial of them. It's not necessarily like if it doesn't work in 3 weeks, then it's not going to work. But those subclasses, gabapentin, Lyrica, there's Cymbalta is another one that helps with nerve pain. And then there's some tricyclic antidepressants, which actually were antidepressants. And then they found out they're way better for nerve pain. So, you know, we're always learning in medicine, but those are kind of like the good front runners for that, for those neuropathic pain meds.
Great. And then Kim asks, will you be doing another presentation? We had an electrical glitch and lost our internet connection until you were taking questions. And luckily, she doesn't have to do another one because both Illinois Bone and Joint and the YMCA will be posting it on our websites. So you will have access to the presentation afterward. I don't know if you knew that, Dr. Gates.
Oh,
but,
no, that's great.
Yeah, people will have access either through Illinois Bone and Joint Institute's website or through the WISEB website. And let's see, we've got a couple more, and I'm going to ask people not to send any more questions because I think we could probably do this all night, and that's probably not fair to you because I know you have an 18-month-old at home. Can degenerative disc disease be reversed with exercise? Can a curved spine be corrected with exercise? That's from Janine.
You know, Janine, the degenerative disc disease does happen over time. You actually will likely see it somewhere around like 9 out of 10 MRIs that get taken, or people will have degenerative disc disease. So it happens. It's like a very common component of aging. The exercise portion of it, the thought is anything that you can do to strengthen the muscles around that spine, right? It takes pressure off of those. Degenerative disc disease is just those discs starting to become little pancakes. They get flat because of, you know, over time, those bones really put a lot of pressure on them. So anything that you can do to take that pressure off, mainly by doing core strengthening or building up the strength of either your lumbar spine or your neck, depending on where you need it, right? That definitely can, you know, reverse some of it, some of the pain that's coming from it most specifically. So that the curve, you know, the more you can do obviously to strengthen the side opposite of the curve, kind of the better off you are. And so same thing, right? Build up that musculature around the spine, but it's always nice to have someone who is trained to give you certain exercises for that to help. It's not just like run-of-the-mill exercise that takes care of it.
Great. All right, and we have Carol going back to the radio frequency ablation and asking, would it help for bad ankles?
It's only at this point really marketed for low back and neck. Unfortunately,
like,
they used to have it for the knees, but they're kind of, you know, shying away from using it for the knees as well.
Okay. And is there any research on whether CBD cream is as helpful as the other topical agents that you recommended?
You know, they're still coming out with a lot of data, obviously, about the CBD and kind of like the medical cannabis side of things. All I specifically know is that it very much so depends on the dosage that is in that CBD cream, and it's, you know, there are a lot of what they call endocannabinoids that are involved in the pain processing pathway, and that's kind of what all of the CBD or all, you know, the medical cannabis is targeting. So some people do get some pretty good luck with it. I have not found that it's like particularly, you know, I don't have people coming in hordes being like, this has changed my life. It's
Gotcha.
my greatest thing. So I haven't necessarily seen that it's superior to anything else that people are using for topicals, but you know, jury's still out.
Fair enough. We've also gotten a lot of thank yous. So thank you very much for this presentation. And Roberta says, thank you for the presentation. How do we get a hold of you for an appointment?
That's so, okay. I have a scheduler through IBJI, so if they call central scheduling, I might let Lori kind of weigh in on that. They can definitely, I am available. I'm in Glenview and Gurnee and Wilmette, so I am very mobile, so can see anybody for anything. I'm here to help.
Wonderful.
There's
So
two
they can
ways.
probably go-
Sorry,
go ahead.
Karen. I was just going to say there's two ways that you can get more information about Dr. Gates. You can go to our website, which is ibji.com, and search under doctors, enter her name and her information. We'll come up with her locations. And if you would like to call, you can also call. She is in Glenview, and I know that number. I'm sorry, I'm not familiar with the other ones, but if you need to reach her in Glenview, you can reach her at 847-998-5680. Thanks, Karen.
Oh, wonderful. Thank you. And thank you, Dr. Gates, for a wonderful presentation. Thank you, everyone who joined us for the presentation today. We really appreciate that you came out for this. And we are doing another presentation with Illinois Bone and Joint on June 24th at 3 p.m. We're going to be covering summertime foot and ankle pain. And I apologize, I don't have the doctor's name. Lori, what is the name of the doctor who's going to be doing that presentation?
Dr. Brian Waxman.
Thank you. Dr. Brian Waxman will be doing that presentation. So thank you all for joining us again. We hope you have a great day. Dr. Gates, thank you for the wonderful information, the great slides and graphics, and I hope everybody has a wonderful day.
Yes, you too. Thank you so much.